All right, we're going to do this. This is going to do the double contrast study. The high density barium, I use about 58 cc's. If it's less than 55, it's going to clump up. If it's more than 60, it kind of washes out, in my opinion. When you pour it in, you have to shake it super vigorously, pound on the bottom because it'll settle. Keep it face down so that when you give it to the patient, you'll turn it over and shake it again so it doesn't clump up. Then when you give the patient, I use 2 packets of gas granules with 20 cc's of water. And I instruct the patient, we're going to be giving you these granules. When I add water to it, it turns to carbon dioxide, seltzer gas. It's foamy, it's acidy, has a bitter taste. Don't chew it or keep it in your mouth. Swallow it down. Once it hits your stomach, you're going to feel like you had 2 cans of soda. You're going to feel like you want to burp. Try very hard not to burp. You may have some, but when you know it's coming, it's easier to hold. I will set up the gantry and pull it over. I will then put the patient, I'll put the machine at mag 1 and I will collimate so I am ready to go. Then I give the patient the gas granules with the water. Here it is. Just swallow it down real fast. Now hold this cup in your left hand. I pull over the gantry, turn slightly to the left, only about 25-30 degrees. You want to have the images paralleling as much of the esophagus as possible and including the esophagogastric junction, usually on mag 1. Then I'll tell the patient, drink the liquid as you would drink any other liquid. Not too fast or too slow, just I'll tell you if you have to change it. When they drink the high density barium, some people will take little sips. It won't fill the esophagus well. You need to have the esophagus distended with the barium and coated on all walls. If the barium column is all the way up, tell the patient to stop drinking, and then hopefully the barium column goes down and the air from the stomach goes up, and you get double contrast images. Try to get 2 or 3 of those. If the patient is drinking too quickly, slow them up. Try to get 1 oblique, then the other oblique, have the patient drink the rest. This process should take no more than about 45 seconds. You don't want to over-distend the stomach. Then you take the cup and you put the patient down. Table's going down, you get the patient a pillow. But you want to get the patient down very quickly because you don't want the contrast to go beyond the stomach or the duodenum. We don't use glucagon or anything to keep stuff in the stomach. It's too inefficient. When the patient is supine, you do 2 rotations. Please turn to your left and onto your stomach. And now turn onto your side toward me. You keep them on their right side down only for a moment. Turn back onto your stomach and roll back onto your back. The reason you want to keep on the right side down is because you don't want the stuff going to the duodenum. Turn to your right, you're not coating the posterior wall of the antrum, only for a moment. Now turn to your left again, back all the way onto your stomach. So there are 2 360-degree rotations. Don't burp. Turn onto your side toward me. 1 more time, back onto your stomach. Go back onto your back. Turn to your right. And now turn again for a moment and turn to your left. This removes the barium from the antrum. Now turn flat against the table, flat on your back. I call this position 0. I will get an AP view, usually in mag 2, but you don't have, or collimate if you're necessary, and an AP view, which will give you much of the upper body and the main body. Then slight RAO, right anterior oblique, hopefully with some barium in the, with air in the antrum and sometimes into the duodenal bulb. Then, as necessary or as provided, I will have the patient turn to the right and get a slight RPO. All of these is what I call position 1. And what you're trying to do is get the picture so that the groups of bowel, if some have reached the small bowel, are out of the way. Position 2 is a right lateral. Turn onto your side toward me. Now, if you have air in the fundus of the stomach, I just take that picture. If there's barium in the fundus, a little bit, what I'll do is lift the table 20, 30 degrees as needed and get it lateral. If there's a lot of barium in the fundus, what I'll do is have the patient turn onto their stomach, and what will happen is, since the fundus is posterior, the barium will go anterior. I will lift the carriage up then, 30, 40 degrees, put the patient back in the lateral, and get that shot. I always have more than one picture of everything. I hate to see something on one image and I don't know if it's real or not. So then I will put the patient through another rotation. Please turn to your left again and all the way. This is another coating of everything, so hopefully you're getting better coating. Again, short time on your right side, then back onto your stomach, roll back onto your back. So this is just a repetition of what we did. Rotate to the right and to the left, Okay, and one more time to the left. And now I go back and back onto your back. And I will repeat those images that I need. Whatever it is that gives me a nice stretch of double contrast anatomy. So usually that'll be another position 1, which I now call position 3. A slight RAO is position 3. Sometimes 1, sometimes 2 views, depends on what you need. If you get the antrum well seen on the opposite oblique, you can repeat that. Then the final thing we do is position 4. Turn all the way onto your side. This time, you purposefully straighten your legs and tell the patient you're going to be standing. What I often will do is keep my hand on the patient's knees, make sure they're buckling. If they don't speak English, they're going to collapse on you because they don't like stand straight. Then I will get a picture. You want the table to be 50 degrees erect. You get repeat lateral. My preference is remember, for all these pictures, stop breathing. If the patient understands that to take a deep breath in, explain it just means stop breathing, because you don't want lung in the picture, you don't want motion. Then you repeat that lateral, and then you get the oblique. Turn partway toward me. This should be about 45 degrees. Don't say 45 degrees, patients don't know what you're talking about. That turn partway, you make the control. Notice how a lot of times I'm holding onto the patient's hips and thighs. It's very confusing for the patients, right, left, so when I'm using the hands, I'm helping them to understand what I mean. I get this view at 45 degrees. The table has to be up 50 degrees because if the table is down, the barium is just going to roll back into the fundus. Okay, after that is obtained, that technically completes the double contrast phase. Now lie on your back. Most of these pictures are obtained with the patient on their back. Therefore, the anterior wall of the stomach is under-evaluated. So what you need to do is get at least one compression spot image of the distal body and antrum of the stomach. The easier way to do it is that the patient is semi-erect. There'll be barium in the body and antrum of the stomach. You inflate the balloon and underfloral, usually in the swimmer's position or a slight RAO equivalent. You just press out the body of the stomach. If you've got a good double contrast bulb, you can get that too. That's 1 or 2 quick pictures. Okay, if the barium is completely out of the stomach, you'll have to do something else, which I'll explain next. At that point, the table goes supine. And you can tell the patient the double contrast portion, the part by part you hold on to the air is over. You can work out the air anytime you want to. In fact, getting rid of the air is better than anything else. Okay, now please turn onto your stomach. This is the single contrast phase of the study, and I put the patient in the swimmers. There were 3 aspects to the swimmer's position. One is the right arm must be by the side, and that's the first thing you have to do. Nothing else will happen if they're not by their side. Now turn onto your side toward me, but keep your right arm by your side. Turn a little more, good. The patient should be on their right hip. Make sure the shoulders go up. Sometimes the hips go up and the shoulders stay down. And sometimes you don't have to, but to sometimes stabilize the patient, you have them cross their legs. Okay, at this point, you can opportunistically look in the abdomen. If you have a well-distended duodenal bulb and duodenal sweep, get those pictures. If you have not been able to get a good barium-filled antrum because it was empty, you put the compression paddle underneath the patient, slip it underneath them, floral, pull it back, and then inflate the balloon. Don't inflate the balloon until you put it in place, and it compresses the antrum and the body. So you can get that picture at that time. Then you give the patient the thin barium liquid. This is a thinner liquid, it tastes thinner. Now, keep your head on the pillow. You must always have the head on the pillow, never double the pillow, because if you're going to hit the patient with the carriage, make sure it's here. I want to emphasize, when you do all of these pictures, you want the carriage to be as close to the patient as they can, but you don't want to hit them. But you can actually see, these machines do not move up and down, so you can choose the height. You want to be as close as possible, less scatter, less radiation, and better images, so that's magnification. Move the pillow over to the side, keep your head on the pillow, put the straw in your mouth, and don't drink. Whenever you put a straw in someone's mouth, you tell them not to drink. Then, the first thing you're going to do is you're going to evaluate for the primary peristaltic wave, something you cannot do in the erect position. Start in the neck area, usually it's MAG 1, always collimate down, make sure the patient's straight so that the collimation is paralleling the spine and the esophagus. If it's not, if the esophagus and spine is going at an angle, strengthen the patient before you start. Start so you're seeing the oral pharynx and the bottom of the nasopharynx. Instruct the patient, take one mouthful of the liquid and then drink it. Only if there's anything left in your mouth, keep it there. And take the patient swallow, and you follow the primary peristaltic wave to the stomach, and then you save it. If the patient takes more than one swallow, it's invalid because you're not evaluating primary peristaltic wave. You may have to coach them a little bit. The patient speaks Spanish and you don't, trague uno seems to work fairly well for me. They understand one swallow. Sometimes it's a problem, you may need to get someone to translate it. Then I always check it twice. I save the video if it's one I want to save. If it's not showing me anything good, there's no reason to save it. Once you've established the primary peristaltic pattern, whether it's good or not good, if it seems abnormal, show that at least twice. And so you may want to save 3 or sometimes even 4 videos if the pattern is complex. If the patient has a significant motility abnormality, you want to show that as well. After that, rather than you're no longer looking at the swallowing function, you park the carriage slightly above the thoracic inlet, well above the clavicles, including the very bottom of the cervical spine. And then you tell the patient, drink as quickly and as fast as you can. The patient drinks, and if you have a good full contrast column, then you move down and you include the esophagogastric junction by keeping the trigger on with an exposure every 2 seconds. That's at the 0.5 frames per second. You have to keep your finger on the trigger. You can't fluoro, take a picture, fluoro, and then take another picture with this machine, unfortunately. If the upper esophagus or any portion of that column is not optimal, stay in that position until you get it right or as distended as it's going to be, and then move down. Don't try to follow the esophagus up and down. It won't work. For routine double contrast, the 2 positions are a right anterior oblique, the swimmer's position. If there's any esophageal pathology or something that bothers you, you can add a lateral. I'm going to do that now. Now, what I want you to do is turn on your side toward me. The up arm goes above the patient's head. The patient holds it with your help this way with the straw in the mouth. Don't drink. You set up the machine. You make sure that you're in a good lateral by showing that the ribs aren't overlap, or the ribs overlap nicely in the vertebral bodies. And then you do the same thing, not the swallowing of the esophagus, but the full column, again, from the thoracic inlet all the way down. That's optional if there's something that you see in the esophagus or it's an esophageal pathology case. The other position that is always mandatory is the opposite swimmers. I usually do tell the patient to lie on their stomach, then they get it. Then the patient goes down, the arm goes down. You hold the cup in the other hand, turn up on your head this way. Okay? And then you fluoro, you want to make sure it's straight. And then once again, the instructions are drink, drink, drink as fast as you can, and you encourage drink, drink, drink. When, in all positions, you start taking the final picture of the Ichi junction, tell the patient stop drinking. Anything they drink after that point is a waste of time, and then they're just drinking barium for nothing and they're getting full. If you want to get a 4-view esophagram, if you want to get a view of the esophagus in the frontal position, the way you do it is the patient is prone, and they have to be on their elbows. Therefore, and you do that if there's a question of right to left shift, the buried subclavian arteries, mass effect that's extrinsic on other views, and you want to see what it looks like in the AP. Under those circumstances, you have to keep the carriage much higher because the head is high, and then you just have the patient drink and get the AP. So that's the frontal view. It's not commonly done, but that's how you would do it. Okay. Then after you've done that, when you've had the patient in the opposite oblique, going back to the way we were, the next thing that's going to be left is you're going to be putting the patient on their back. But before you do, fluoroscope that there's no contrast left in the esophagus. Because if contrast shows up in the esophagus after this point, you want to be able to tell if it refluxed or if it was due to barium that was still there. You don't want that there. Okay, so there's nothing there. If there is some barium left over, you can tell them to do a dry swallow. If they have a motility issue with stasis in the esophagus, give them some water till it's washed out. You don't want anything in the esophagus. Now turn onto your back. At this point, you do a timeout. Have I gotten my duodenal sweep, my duodenal bulb? Were there any things that I wasn't sure about? Then we evaluate for reflux. For reflux, one is spontaneous reflux. If at any point when all this is going on, you see reflux happening, save the video so you'll remember it and you'll have the documentation. The next thing I'm going to do is I'm going to have you strain. So what I'd like you to do is to strain, depending on the age of the patient, like you're doing a crunch, tightening your stomach muscles, lifting your box. Don't do it yet till I say, as if you were sitting up. Or I'll say, here, do the stomach muscles, tighten them up. What I'll have them do is I will start in the supine position and then gradually rotate them as they continue to strain, because the EG junction and the barium that can potentially float again with gravity into the lower esophagus, that EG junction may not be in the supine, it may be on the oblique. So strain, 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 turn to your side toward me. Don't lift your head, strain, and I do it every 5 or 10 degrees, strain, 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 and then back onto your back. If you have to do it twice, do it twice. But no more than about 10 seconds, that's too difficult. The next thing for a Valsalva maneuver, they actually have to Valsalva. Please turn all the way onto your stomach, toward your stomach, and you're watching the screen as it goes all the way around. Now turn back onto your back and strain. Those are the two things that you do. The final thing is the water siphon test. The cup should be filled about 2/3. Add a little bit of barium, just a touch, so you can see it going down. And you give it to the patient with a straw. So what I'm going to have you do, sir, is this is water. It has a little bit of the white liquid so I can see it. Hold the cup. You have to balance it for the patient in their right hand to destroy your mouth, but don't drink. Keep your left arm by your side. What I want you to do is to take a swallow, take a deep swallow, a fast swallow, and then strain. And then another big swallow and strain. So you're swallowing, straining, swallowing, and straining. You're in position. Again, you want to be centered on the fundus in the lower esophagus. Have them strain, swallow and strain, swallow and strain, swallow and strain. When you see it start reading from the stomach, after 1 or 2 swallows of each, turn toward your right a little bit, swallow and strain. Turn more, swallow and strain, and sometimes you need to be at 45 or even 50 degrees to be profiled to the EG junction and have the barium reflux. If you're not sure, you can give them another cup of water and do it again. And that's basically it.